This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. Hey, podcast listeners. We know you're tuning into this episode despite your busy schedule because you want to stay up to date in your NP practice. Good news. There's another way we can help, and it comes with the opportunity to earn your required CE and advanced pharmacology credits from home or on the go. This fall, join us for the National Conference for Nurse Practitioners, a twice-yearly virtual event sponsored by us at the podcast. With over 35 sessions delivered by expert speakers on a broad range of clinical topics in primary, urgent, acute, and emergency care, NCNP has you covered. You and your peers will enjoy talks on clinical guideline updates, best practice advancements, and professional development trends in all specialty areas. Attend the virtual event live from October 18th through the 20th, 2023, or tune into recorded sessions at your convenience anytime during the 90 days after the live stream event. Either way, you can claim up to 55 CE credits and 30.5 advanced pharmacology hours through the 90-day deadline. Visit tnpj.com and click the NCNP tab to learn more and register. We look forward to seeing you. In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers discusses pulmonary fibrosis, presentation, manifestations, and treatment. Welcome, Julia.
Hi.
Can you give an overview of pulmonary fibrosis and the importance of understanding this disease?
Well, the short explanation is that pulmonary fibrosis is a progressive inflammatory pattern that causes scarring or fibrotic lung tissue. It's not a cancer or an infectious process, and while it can coexist with an obstructive lung disease, it is actually considered a restrictive disease that falls into the category of interstitial lung diseases. Ultimately, pulmonary fibrosis is the general term that refers to any interstitial lung disease in which fibrosis is present. Fibrosis affects the spongy parts of the lung and causes abnormalities within the alveolar walls, or also known as the interstitium. A chronic inflammatory response causes the interstitial spaces between the alveoli to become scarred, fibrotic, and thickened. This then leads to stiff and non-compliant lungs, which causes a lot of difficulty for the oxygen to diffuse into the bloodstream. This causes a person to have increased work of breathing, impaired gas exchange, and low oxygenation. Pulmonary fibrosis has a high mortality rate with a life expectancy of only 2 to 5 years after the presentation of symptoms. Therefore, it's really important for all nurse practitioners to understand the disease and know the signs and symptoms in order to provide a timely diagnosis.
Thanks for the overview. Is there a specific cause of the disease?
Yes and no. Funny how that can be answered in both ways, so let me try to explain. Nearly all pulmonary fibrosis cases are idiopathic, meaning there really is no exact cause. However, what we do know is that fibrosis occurs in over 200 related conditions. This includes disease processes that are lung-limited, as well as systemic conditions. For example, patients with autoimmune disorders, which are systemic, may have pulmonary fibrosis, or it can be related to an environmental, occupational, or medication exposure. Some examples of interstitial lung diseases that have a known cause and actually cause fibrotic tissue include connective tissue disorders. So these are autoimmune diseases such as rheumatoid arthritis, scleroderma, and Sjogren's, which can damage the lungs and cause connective tissue disease associated with interstitial lung disease. Actually, sometimes it is the interstitial lung disease that is the first manifestation of a connective tissue disorder. This is why it is important to take the time to carefully question the patients about any symptoms that could indicate underlying disease, such as joint pain, stiffness, or swelling, any skin thickening or tightening, if they've had a rash, dry eyes, or dry mouth, a history of Raynaud's phenomenon, or diffuse recurrent muscle pain or weakness, and severe heartburn with gastric regurgitation. There's also a number of medications that are known to have lung damage as a possible side effect. Therefore, nurse practitioners should not only obtain a current medication list, but also review any past medications that they may have used for cardiology, an autoimmune disorder, or any cancer treatments. Medications that have been implicated in pulmonary fibrosis are amiodarone, nitrofurantoin, methotrexate, and certain chemotherapy agents. There's also environmental stressors, such as smoke or dust and air pollution, that can cause epigenetic changes. Therefore, when gathering a patient's history, it's important to consider both current and past environmental factors that could contribute to pulmonary fibrosis. You should also ask patients about inhaled mold spores or bird proteins, because either of these can trigger inflammation and subsequently fibrosis. Questions regarding being around dampness or mold or bird exposure, both in the home or workplace, should immediately raise suspicion for nurse practitioners for a possible pulmonary fibrotic relationship to hypersensitivity pneumonitis. Another potential factor is silica exposure. We know that silica has been implicated in increasing the expression of DNA methyltransferase 1 in patients with pulmonary fibrosis, which leads to the accumulation of collagen and lung fibrosis. Radiation is yet another environmental factor to inquire about. So you want to ask the patient if they have worked around or been exposed to radiation of the chest or ever received any type of radiation therapy. There's also a variety of workplace exposures that are potentially toxic to the lungs. Black lung and coal workers and asbestosis are two well-known examples. Although there's been significant improvements in occupational safety, there is still occupational factors that remain an important cause of interstitial lung disease. So obtaining a thorough occupational history is critical, including any time served in the armed forces, especially in naval shipyards, if they've had exposure to asbestosis, such as coal workers and contractors, anyone that is a sandblaster or holds any position that exposes them to chemicals, toxic materials, or inhaled metal dust.
That was a fairly long list of potential causes. Are there any other possible etiologies?
Yes, there are also certain genetic mutations that are linked to pulmonary fibrosis. Telomerase reverse transcriptase, or TERT, and also telomerase RNA, or what we call TERC, are gene mutations which are major monogenic causes of pulmonary fibrosis. TERC and TERT are found in about 15% of all the familial cases of pulmonary fibrosis. One other that I think is important to discuss is post-infectious pulmonary fibrosis, which includes COVID. Microorganisms such as viruses, fungus, and bacteria all play a potential role in the pathogenesis of pulmonary fibrosis. And we know that patients with pulmonary fibrosis, as compared to patients without pulmonary fibrosis, have an imbalance in the composition of lung microbiota, which can serve as a persistent stimulus for repetitive alveolar injury. The inflammatory and fibrotic mediators and immune disorders in the lungs of fibrotic patients are related to a bacterial load. Now, while the evidence that viral infection in general may elevate a patient's risk for pulmonary fibrosis, remains mixed and inconclusive, there still appears to be an association with chronic viral infections. The Epstein-Barr virus, cytomegalovirus, and herpes virus are all viruses that are detected within alveolar epithelial cells of patients with interstitial pulmonary fibrosis, which actually suggests a link between viral infection and increased risk of pulmonary fibrosis. In addition, it is thought to occur secondary to viral pneumonia, especially COVID-19 infection. This is because pulmonary fibrosis can occur following acute respiratory distress syndrome, or ARDS, which occurs in a subset of patients with COVID-19. The highly atypical inflammatory responses seen in COVID-19 have complicated analysis of the relationship of this viral infection to pulmonary fibrosis. So while COVID-19 may not be the driver of the increasing incidence and prevalence of pulmonary fibrosis, it is not necessarily unrelated.
Thanks for sharing. What are the signs and symptoms nurse practitioners should be aware of that are associated with pulmonary fibrosis?
Symptoms may be mild or even absent early in the disease process, but as the lungs develop more scar tissue, then the symptoms will worsen. The two symptoms that are most prevalent are dyspnea and cough. The shortness of breath usually has an insidious onset that initially occurs with exercise or exertional activities. But as the disease progresses, patients may become breathless while taking part in everyday activities of daily living, such as showering, getting dressed, even speaking on the phone, or even while eating. A cough generally ensues with or slightly after the onset of shortness of breath. The cough really comes from mechanical stress from the fibrotic tissue that's actually pulling apart those small airways. And that is what contributes to cough in pulmonary fibrosis patients by sensitizing rapidly adapting receptors within the peripheral airways, thereby lowering the cough threshold. Another possibility is due to the matrix stiffening of the lung tissue, which is a prominent feature of lung fibrosis. Patients generally describe the cough as dry, hacking, and non-productive. Another sign is hypoxemia with oxygen saturations well below 88%. Because of the hypoxia, patients may also show nail clubbing or cyanosis. Another exam finding that is very apparent in patients with pulmonary fibrosis is having fine crackles, generally bilaterally and in the lower lobes. It is important for nurse practitioners to document where they hear the crackles, whether it's the lower fourth, lower third of the lung, so that as the disease progresses, you can see if those crackles are moving upward.
Thanks for letting us know what to look out for. Are there any diagnostic tests to determine if someone has pulmonary fibrosis?
Pulmonary fibrosis is diagnosed after a complete history, physical exam, blood work, and other workup actually fails to identify another known cause. Because patients with vague symptoms present, the diagnostic workup usually begins simply with a spirometry, a chest x-ray, and possibly some lab work. Then it progresses to a complete pulmonary function test with a diffusion capacity, then obtaining a high-resolution CT, and a 6-minute walk test. In some cases, a confident diagnosis can actually be made on the high-resolution CT, but in other cases, a lung biopsy may need to be performed in order to make that diagnosis. In the 2022 updated interstitial pulmonary fibrosis guidelines, a conditional recommendation was made to regard the transbronchial lung cryobiopsy as an acceptable alternative to surgical lung biopsy, of course in centers with appropriate expertise. And there was no recommendation made for or against genomic classifier testing.
Can you explain the benefit of obtaining a complete pulmonary function test in a patient with possible pulmonary fibrosis and what the results may show specific to the disease process?
Pulmonary function tests usually demonstrate a restrictive pattern with a reduced forced vital capacity, or the FVC, and also show a reduced forced expiratory volume in 1 second, or the FEV1. And they also have a reduced diffusion capacity of the lung carbon monoxide, or DLCO. But typically, they have a normal or more than 70% ratio of that FEV1 to FVC. In fact, patients with early disease may have normal values on their pulmonary function tests. Lung volume measurement also gives many results, but the most important is the total lung capacity, that TLC, and that is the volume of air the lungs can hold during the deepest possible breath in. Just like the FVC, the TLC can be normal in early disease and will decline as the disease progresses. When TLC is reduced, meaning less than 80% or so, the term restrictive ventilatory defect is often used. One of the most important indicators in the complete pulmonary function test is that diffusing capacity of lung for carbon monoxide, that DLCO, and that gives a measure of how quickly gas can move from inside the alveoli through that thickened alveolar wall and into the bloodstream. The DLCO is generally reduced less than 70% in almost all cases of pulmonary fibrosis. But if a patient has a normal DLCO, that really makes any interstitial lung disease very unlikely. Like the FVC, the DLCO decreases as the disease progresses and is often measured at all or most follow-up clinic visits. The presence of abnormal pulmonary function test findings can assist in making sure that those that suggest interstitial lung disease would then obtain a high-resolution CT.
You mentioned that a high-resolution CT is an important diagnostic test to obtain if the nurse practitioner suspects pulmonary fibrosis. Can you talk more about this test and why it is important?
A high-resolution CT is important because pulmonary fibrosis may be diagnosed just on the results of that high-resolution CT alone. When ordering a high-resolution CT of the chest, it should be performed without contrast. On CT imaging, abnormalities such as inflammation of fibrosis in the lung, varying degrees of white opacities are noted within the lung, also with structural changes such as honeycombing or traction bronchiectasis and reticulation. Honeycombing is a distinguishing feature and is essentially due to fibrosis. It must be present for a definite high-resolution CT diagnosis of usual interstitial pneumonia, or UIP, to be made. However, while honeycombing is common in pulmonary fibrosis, it is not specific for pulmonary fibrosis. Honeycombing is caused from thick-walled linear cysts, often occurring along the periphery of the lung. Traction bronchiectasis is the term used when there are dilated airways due to the fibrosis. There may also be reticulation or irregular intersecting white lines noted. Reticulation just indicates that there is fibrosis present. All forms of pulmonary fibrosis have reticulation. The peripheral reticular opacities are usually most notable in the lower lobes.
Are there any labs that are beneficial in differentiating pulmonary fibrosis from other diseases?
There is no lab test that is specific to pulmonary fibrosis. However, blood tests can be valuable in excluding other diseases with a similar clinical presentation. The presence of autoantibodies is suggestive of interstitial lung disease that is associated with connective tissue disorders, as I talked about earlier, such as rheumatoid arthritis and lupus. So some lab tests that could be done are the ANA, RF, and anti-CCP antibodies. Raised levels of serum immunoglobulin G against microbial, avian, and other environmental exposures can actually be pretty informative in cases of suspected hypersensitivity pneumonitis. Blood test results should not be interpreted in isolation, but more as a part of a comprehensive clinical evaluation.
Thanks for sharing. What are the treatment options for patients with pulmonary fibrosis?
First, let me start with medications. There are two antifibrotic drug therapies, pirfenidone, and nintedanib. And they are available to help slow the disease progression and reduce mortality. But there is still no cure. The 22 guidelines have conditional recommendation for nintedanib, and additional research into pirfenidone is what was recommended. Pirfenidone is an oral pyridine that has anti-inflammatory, antioxidant, and antifibrotic effects. The dose is 267 milligram capsules or tablets that are titrated up to 3 capsules orally 3 times a day with meals over 14 days. Once the patient is on a stable dose, then an 801 milligram tablet that is equivalent to 3 capsules is available. Nurse practitioners need to make sure to monitor adverse reactions on pirfenidone, such as nausea, rash, abdominal pain, upper respiratory tract infection, diarrhea, fatigue, dizziness, anorexia, and of course, gastroesophageal reflux. The one warning and precaution is elevated liver enzymes. Therefore, make sure that you are checking that AST, ALT, and bilirubin before you start the medication, and then again after you've started the medication, and continue to monitor those liver function tests during treatment. You may have to have a temporary dosage reduction or even discontinue if the liver function tests continue to rise. There are a couple drug interactions to watch out for, so ciprofloxacin, for example, and also strong inhibitors of CYP1A2, so for example, fluvoxamine. These increase systemic exposure of pirfenidone and may alter the adverse reaction profile of the drug. Next is nintedanib, and this is a tyrosine kinase inhibitor, and it's available to help slow the disease progression in systemic sclerosis-associated interstitial lung diseases, and also in chronic interstitial lung diseases in which the fibrosis continues to progress. The dosing is 150 milligram capsules, 1 capsule every 12 hours taken with food. Adverse reactions here more commonly are diarrhea, nausea, abdominal pain, and then also liver enzyme elevation. So again, we need to make sure that we are monitoring the liver function tests, and it also can cause hepatic impairment. So it is not recommended for use in any patient that has moderate or severe hepatic impairment already. Again, make sure that you're monitoring that AST, ALT, and bilirubin prior to the initiation of the treatment, and then at regular intervals, definitely during the first 3 months of treatment, and then periodically after. It also can cause embryo-fetal toxicity, so make sure to advise females of reproductive potential that there is a potential risk to a fetus, and to make sure to use effective contraception. Some drug interactions are the P-glycoprotein and CYP3A4 inhibitors. So some of these drugs you would know by clarithromycin, erythromycin, itraconazole, midazolam, and verapamil, because these may increase nintedanib's exposure. The other one that I want to talk about a little bit is prednisone therapy. So in the past, before we had these amazing medications to place patients with pulmonary fibrosis on, prednisone really was the standby therapy. But now the suggestion is to only use prednisone therapy when a patient is having an exacerbation. So only acute exacerbations may be treated with corticosteroids. Prednisone is used because it is a therapy that reduces inflammation. And before these medications, the antifibrotic medications came out, it was the standard med. Now steroids are used, again, only for the exacerbations. Steroids can cause long-term issues with patients and can be harmful. So make sure that you are also looking at the side effects of prednisone when you are using it for exacerbations, because it may increase the susceptibility to infection. It can cause fluid retention, weight gain, insomnia, osteoporosis, and fractures. It also increases blood sugars for diabetics, can cause hypertension, and also fragile skin and bruising.
Thanks for sharing those treatment options. Earlier, you had said that patients with pulmonary fibrosis have dyspnea and hypoxia. What type of evaluation should you perform to determine if a patient needs oxygen, and what are the benefits?
One of the most common symptoms of pulmonary fibrosis is that the patients experience dyspnea on exertion. Because of the nature of the disease, it really is not unusual for a patient to have a resting oxygen saturation within normal limits and then desaturate significantly with activity. The increase in cardiac output during exertion means that there is less time for the oxygen to diffuse from the alveoli through that alveolar capillary membrane and into the bloodstream. So as the disease progresses, desaturation becomes more severe and occurs with lesser degrees of exertion. The need for supplemental oxygen is often tested at rest and then during exertion, and when indicated, during sleep. Now, insurance has very particular guidelines for determining the need for supplemental oxygen. If the oxygen at rest or with exertion is not indicated, then of course you can order a nocturnal oximetry test or a polysomnogram in order to determine whether oxygen is needed during sleep. The 6-minute walk test is what is completed in order to determine if a patient needs oxygen. What this test will measure is the measurement of distance walked in 6 minutes, the lowest saturation during that time, the end walk saturation, and of course, the heart rate recovery. These data, particularly any changes over time, help inform a prognosis. A patient requires supplemental oxygen when the O2 saturation is less than 88% or the PaO2 is less than 56. When the SpO2 is 89% or the PaO2 is 56 to 59, oxygen can be prescribed, but only if your patient also has dependent edema or pulmonary hypertension or cor pulmonale, determined by the measurement of the right heart catheterization, an echocardiogram, or an EKG, or if the patient has a hematocrit more than 56%. If patients require oxygen, then you have to make sure that you are demonstrating how a pulse oximetry should be used, how the oxygen should be used, and then also encourage the patient to not live by those numbers on his or her pulse oximeter.
We appreciate your insights. Are there any treatments to help with symptoms related to pulmonary fibrosis, such as cough?
The first requirement before treating the cough is to determine if the cough has another etiology. For example, the nurse practitioner should inquire about any allergies, postnatal drip, or if the patient is on any medications that may cause cough, such as an ACE inhibitor, or if the patient has acid reflux, if they are smoking cigarettes, cannabis, or they have inhaled irritants, or if they have a history of asthma, COPD, or airway sensitivity. Patients with pulmonary fibrosis are more sensitive to these things that already cause a cough. And so they also have specific triggers within the airway, and they have mucosal changes as well as stiffness and fibrosis. If there are contributing triggers to the cough, then treat those underlying conditions. Now, a cough suppressant can be used such as guaifenesin or benzonatate, but it can only be used after pneumonia has been ruled out.
What are the recommendations in treating or controlling GERD?
In the 2018 guidelines, it was recommended to treat patients that have fibrosis with antacids or anti-reflux surgery. But then in 2022, the conditional recommendations were made against antacid medication and anti-reflux surgery for the treatment of pulmonary fibrosis, or for just the purposes of improving respiratory outcomes. Now, if the patient does have GERD as a comorbid condition and is symptomatic, then it should be treated by using a proton pump inhibitor or an H2 blocker, and then sometimes surgical intervention may be needed.
How can the nurse practitioner help with the fatigue aspect?
It is important that nurse practitioners determine the underlying cause of the fatigue and then treat that. So some possible differential diagnoses to look at are, does the patient have sleep apnea? Do they have anxiety, depression? Or do they have any psychological or social stressors? And any other medical comorbidities, or also the deconditioning that exists because a patient has pulmonary fibrosis.
Does increasing activity or exercising help these patients?
Exercise is an important component in the treatment and management of pulmonary fibrosis. The health benefits overall of exercise are very well documented and can improve the patient's quality of life. But exercise does not improve lung function in these patients. Now, a person with pulmonary fibrosis experiences a loss of control because of their lung condition. And so exercise becomes a form of self-management. We have to remember that lungs are not muscles. So exercise does not stop pulmonary fibrosis, but we have to be mindful that the rest of the body is muscles and they all use oxygen. So we need to provide the muscles with strength and conditioning. So patients with pulmonary fibrosis should be referred for pulmonary rehabilitation. Pulmonary rehabilitation is a structured exercise program along with educational programs. They provide exercise training, outcomes assessment, training those respiratory muscles. They also provide psychosocial support, nutritional evaluations, and counseling, and increased exercise capacity, which can help reduce symptoms, and these patients then can have a better quality of life along with increased energy.
Thanks for those recommendations. What are other important treatment options for a patient with pulmonary fibrosis?
Smoking cessation for anyone that is a current tobacco or cannabis user or vapes. Any patient that is a smoker should be offered cessation aids. Patients should understand also the importance of vaccines. So influenza, pneumococcal, and COVID vaccines should be followed according to the CDC guidelines and recommendations. Remember that for a patient with pulmonary fibrosis, any respiratory infection can become very serious and life-threatening. And as a result, quality care requires that the nurse practitioners understand these vaccines and encourage patient compliance. Patient education and self-management are critical to help patients with pulmonary fibrosis manage their disease and make decisions regarding their care. Educating patients about the disease and its progression allows patients as well as their caregivers to set realistic goals, feel more in control, and prepare for their future.
Thanks for sharing these other treatment options. Since these patients have a short life expectancy, when should you discuss palliative or end-of-life care?
Palliative care is an approach that improves the quality of life for patients facing life-threatening illnesses and their families by preventing and relieving some of the suffering. This is achieved through early identification, assessment, and treatment of things like pain and other physical and psychosocial and spiritual problems. The focus is more on managing symptoms and addressing advanced care planning in order to improve the person's quality of life. Palliative care actually needs to be offered upon diagnosis of pulmonary fibrosis. Palliative care will involve management of the symptoms, which is relevant even in patients with just mild or moderate disease. Patients can receive emotional and spiritual support to enable them to live better with the consequences of this incurable illness. It can mean that patients are assisted and families are assisted through the process of reflection, discussion, and communication of different treatment preferences and end-of-life care or advanced care planning. This is more of a deliberate, organized, and ongoing process of communication to help an individual identify, reflect upon, discuss, and articulate their values, their beliefs, their goals, and their priorities in order to guide their personal care decisions up to and including end-of-life care.
Finally, is a lung transplant an option for patients with pulmonary fibrosis?
Actually, lung transplantation is the fundamental treatment for pulmonary fibrosis. But the average survival time post-transplantation is 4 to 5 years. And keep in mind that earlier I had stated that life expectancy with pulmonary fibrosis is 3 to 5 years. So many times the life expectancy is about the same with or without lung transplantation. But lung transplantation does help improve these patients' quality of life. There is restricted supply of donor organs, and so there's the limitation of chronic allograft rejection as well in these patients. So there's only a few patients that can actually receive this intervention. These patients who are put on the transplant list can receive a single or a double lung transplant. However, these patients need to meet very stringent criteria before they are even placed on the transplant list. It is reserved as a mechanism to save the life of the patient, not just simply improve quality of life, but again, the survival time post-transplantation is only 4 to 5 years.
Thanks for providing such in-depth information on pulmonary fibrosis. Nurse practitioners would certainly be more equipped to perform a workup and subsequent care for patients with pulmonary fibrosis. Thanks so much. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at TheNursePractitionerJournal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.